Good morning, everybody. Welcome to Unlocking the Healthcare Debate, Reconciling Different Truths. I hope you are all awake and ready for some brain food. And we're going to start this session with a video clip.
I'm still here. The routine keeps me going. Last contact was over 100 days ago. But I know they're doing everything they can. I think of you all every day. Some days, that's the hardest thing to do. Some days, it's the only thing that keeps me breathing. I'm here. I hope you're out there too.
Now, as I hope you've already realized, this is not going to be an ordinary debate on the state of healthcare. You're probably wondering what an astronaut stranded in space has to do with healthcare. Well, the clip comes from a new film called Is Axiom, which uses space exploration as an allegory for what's going on in healthcare systems around the world today. The film had its premiere yesterday here, and you can watch it later if you want to on the Celgene stand in the exhibition hall, or you can watch it on YouTube. And let me tell you, it's worth a watch, just as a piece of cinema, if nothing else. Today we're going to be using a few clips from the film to illustrate our debate. Now, the background is that this film and this event are sponsored by Celgene because it believes that the debate over healthcare, and particularly the role of pharmaceuticals companies, has become oversimplified and polarized. As an example, on the one hand, we all expect new drugs that will save us from an increasingly long list of diseases. But on the other hand, we criticize the industry for charging high prices when they do exactly what we want and come up with a life-saving drug. So the questions are, how do we reconcile these apparently conflicting attitudes? Are we focusing too much on the cost of drugs and not on the value that medical innovations bring? And can we align the priorities of the different groups within the healthcare system to make things better? To help us answer those questions, we have a panel of guests who have experience from a variety of roles across healthcare. Pirella Peralta has come from the Netherlands, where she is a patient advocate at the Inspire to Live Foundation, whose goal it is to get cancer under control in the next 10 years. And as such, it's striving to change the way global cancer research is organized and executed. Stephen Dorrell is chair of the NHS Confederation, but if he looks strangely familiar, it's because he was not only an MP for 36 years, he was also the Secretary of State for Health for 2 of those years, and between 2010 and 2014, he was chair of the Commons Select Committee on Health. Adam Kay is the man who is practicing being a patient at the moment. He is now an author and comedian, but he trained as a doctor and spent several years working as an obstetrician and gynecologist. His first book, This Is Going to Hurt, takes a bittersweet look at his experiences as a doctor. And over here we have Michael Zayak, who is Vice President of Medical Affairs at Celgene. And before moving into pharmaceuticals, Michael was Senior Health Officer in general cardiothoracic and orthopedic surgery. So I think our guests will give us a broad range of views. And let's kick off with another clip. And here we see the flight controller, who is secretly a doctor, trying to get his astronaut, who is the patient, back to Earth. And he's in discussion with his administrator, and that could be a hospital administrator or the Minister of State for Health. Here we go.
We don't have the resources to keep this mission open indefinitely. We have the best technicians in the world under this roof.
Right, yes, we have the best technicians in the world. We have everything we need right here to bring this mission in, but you're just happy to cut our resources.
I am only trying to manage what their position is upstairs. Bluntly, the message I'm getting is we're out of time and we're out of money. The budget for this mission dried up long ago. What resource we have is tied up in other missions. It's horrible, I know. But one astronaut does not justify the kind of money that we're talking about here. I'm sorry. We simply have other priorities.
Okay, so let's start with this notion of the cost of drugs and the value they bring. Michael, if I could start with you, if you could explain to us, how do you see the difference between cost and value?
So cost is what you pay, value is what you get back, the balance. And I think value exists, value for you, the patient, value exists for you, the health system, value exists for me, trying not to be a patient, trying to be part of society. And that's what we have to reconcile. It's very different. The patient sees it different, the healthcare system sees it different, but the majority of medicines we bring actually return on all those three levels more than their cost. And the benefit with each of the medicines is that after 10, 15 years in the market, they return that forever without a cost. And I think that's often what we forget when we look at just one parameter, cost.
Okay, Stephen, do you want to talk to us about how you see value in drugs? And let me, the debate that was going on in that clip was really about weighing up one life against weighing up many. Now, as the Secretary of State for Health, you had to make these kind of broad decisions.
In any society, there are choices about how you use resources. If you're the doctor dealing with a single patient in the consulting room, your prime responsibility must be to that individual. But in a healthcare system that's funded through taxation, or actually in any healthcare system, you also have to make choices which impact on the lives of people who are not in the consulting room, the patient outside the room. So it's that choice about how resources are used that you can't escape. What I think is a mistake in the way you framed this discussion, if I may, is to think that drugs are somehow special in that debate. It seems to me important to recognize that drugs are one cost, staffing costs are another cost, building costs are another cost, and what we should be doing is testing the healthcare system to use all the resources available to it to deliver the best value for patients, and to do it against the recognition that it's one of our successes as a society that we're able to spend more year by year on health and care services, and we shouldn't see the rising budget for health and care services, including drugs, as a problem. We should see it as a demonstration of success, and the question is how we can make certain that growth continues.
Okay, Adam, do you want to, Stephen's just mentioned the doctor in the surgery. How do you feel about it as speaking to patients one-to-one?
It's very difficult. So I worked in obs and gynae, and that includes infertility clinics, which is a very good example of rationing within healthcare. And you find yourself basically breaking bad news to a patient. You're taught how to do I'm afraid it's cancer, and we did everything we could, and all of that. And it's very different to say to a patient something you don't believe, which is the treatment exists, but you can't have it. And even worse, the treatment exists and you can have it, but the hospital I worked at 3 weeks ago, a couple of miles away, you could have it, because there, your age is fine, or there, your weight is fine, or there, it's fine as a gay male couple, but it's not as a gay female couple, or vice versa. Arbitrary guidelines laid down locally mean you have to say to someone, I'm sorry, it is possible for you to have a child, but not in this area. And you say to them, you could look at private IVF, that would work, but that might be about £5,000. And some people, £5,000, fine, but most people, £5,000 might as well be £5 million. It's very difficult.
Okay. And Pierella, Stephen's just made this point that we shouldn't single out drugs. We need to think more widely. Do you think we need to think even more widely about things like prevention as well?
That's one of the things that always come to my head when we are actually in the patient chair and we are thinking of life and quality of life. And there are all these aspects of cost weighing on the whole system. And to begin with is to include patients and citizens more seriously from earlier stages to determine what true value is for us and build upon that. But prevention, it's something that gets left out of the equation. And that's where the greatest societal gain can come from preventing a lot of patients that do not need to become patients.
Okay, all right. Do you think Stephen, you mentioned this broader idea. Do you think we should be comparing drugs to other treatments? I mean, the classic example is the talking therapies that are used for depression, for example, versus drugs like the antidepressives.
Can I answer that by quoting you a specific anecdote? And it comes from the United States. One of the people who, the guy responsible for Medicare, Medicaid, state-funded healthcare in the state of New York, had addressed all of these dilemmas about how to use resources. And he achieved what the accountants wanted. That was to say a sustainable budget. He was asked what was the single most effective intervention he made to deliver good value expenditure for taxpayers in the state of New York for their health care. And he said, I tell you what, it wasn't paying anything to do with health care, it was putting air conditioning units into low-income housing in Brooklyn. Because what that did was to ensure that people didn't present in the emergency room because they didn't need to. So that's the important thing. Thinking of drugs as it is of course an expenditure, and you can't escape from the requirement to agree a price for them. But you have to see them in the context of all the weapons at your disposal. And the question should be not, I absolutely agree we should listen to patients and we must engage patients in healthcare, and absolutely agree with that. But rule one, line one, is to remember that before any of us are patients, we're citizens. And actually, one of my ambitions as a citizen is to avoid being a patient.
Yeah. Okay, good. So a good start, I think. Let's move on to our second clip, and then we're going to put the patient firmly at the center of the debate.
This is Axiom. Come in.
Go ahead, Axiom.
Hi. I need an update, please.
I understand. Thank you for your patience, Commander. We're working on an update for you here.
I'm sorry, Base, but that's not good enough. I need to know what I can do to start the process. Please.
I've run some calculations. I have a better idea of potential coordinates, so let's feed that into the protocol and get a scenario worked up.
We're working on it. I'm sorry, Commander, this is a complex situation, and...
You're telling me? I'm the one out here. God knows where, alone. I need a little assurance that we're going to get me home.
How is that so difficult?
Okay, it's clear that the astronaut, who is our metaphorical patient, is feeling out on a limb, which is strange when you think that healthcare is really all about treating patients. So, Adam, can I start with you and ask, do you think doctors are bad at talking to patients and explaining things to them? And how do we get better?
How do we get better at talking to patients? Well, some doctors are very good at talking to patients, some doctors are very bad. You apply to be a doctor when you're 16, basically when you choose your A-levels, which was a pretty bad age to decide to want to do anything, and you probably don't know whether you're good at breaking bad news or good at, anything. Some doctors are good, some doctors are bad, and you're taught communication skills. You're taught the way of dealing with patients. Traditionally, it would be very patriarchal, didactic. You are having this done. And then there was a move more towards a whole specials board full of options. So, I've broken my ankle. You're meant to say, we could do nothing. We could give you paracetamol. We could put you in a cast. We could give you surgery. We could cut your leg off. Could put you in a coma. And now we've come somewhere back to the middle where we say, there are lots of options. If this were my brother, my sister, my father, my mother, I would suggest immobilizing you for 6 weeks, then re-x-raying. So yeah, some doctors are good and some doctors are bad.
Okay, all right. Do you think there's anything we could do to improve the situation? Michael, you were a doctor for many years.
I'm obviously a few generations before your communication training wasn't part of my bringing up, but I think we're just human beings. I mean, most doctors, if they have to bring bad news, shy away from it. But I think what you said is what we have become better, and what industry potentially also can help is we bring solutions, we bring options. And that's the great thing, is to discuss options with patients. I practiced in a German cancer center as a breast cancer surgeon, and bringing options to patients, having patients being able to discuss what kind of surgery, what kind of pre- and post-operative therapy they wanted is incredibly enriching also for the doctor. And even whilst bringing bad news, I learned that really whilst working to bring that across to patients, to form a unity, to make a decision together. I think that's the strongest thing. I didn't have it at med school, but it came later on in life.
Okay, now Piorella, what do you think of the doctors and what they're saying? How do we stop patients being alienated, or is that the wrong question to ask? Should the patient be in there from the very beginning?
Yes, I think that I agree very much with you. We're all citizens. We want to avoid being patients, but once we are patients, we want a healthcare who doesn't deviate from the essence. And I think that's very important to keep into account from the boardrooms. Have patient advocates, neutral patient advocates who know what the best interests are for the citizens and for the patients. Look at what the ACT-UP movement have done for AIDS patients in solving cancer. Also, palliative care is a great victory for cancer patients. You know, there is a lot that we can bring when we are included in the system, and we depart from this paternalistic point of view, for like, this is how we talk, or this is what we have to do. When we have patients involved from all of the areas, we are thinking of other things, of how we create healthcare in a way that we all see each other as just human beings. This is departing from more a paternalistic point of view, and now we're being forced to work together, you know, to pull together, to create value together. We really do know which way we can go. I mean, I say it once, one more. AIDS was solved ultimately because these patients were relentless in getting trials that really worked for them.
So tell me, how does it work in the Netherlands? I mean, do you sit on the boards of hospitals, research organizations? How does it work?
Well, we are making spaces. We are certainly not there yet, but since we started advocating for this, it was not heard of, and now we are trying to get patients on boards. There is also where they evaluate whether research is patient-friendly, so they also have a commission of patients who give an opinion, but it's not enough. We really have to be in the decision-making chair, really making evaluations and steering the direction towards what are real solutions for patients. There is a lot of ground to be gained. You know, this is the healthcare that goes into the future. It's a future that needs to be led by its essence, the patient.
Steve, what do you think about this idea of patients being involved? You know, all those damned voters. I mean, you'd agree with Piorella, presumably.
Well, I absolutely do. And Andrew Lansley, of late lamented memory, he appropriated a slogan, which actually is a good slogan. It wasn't his slogan originally, and hopefully it can now be restored to mean what it to say what it really means. No decision about me without me. To engage the patient. Not just in choosing, in a crude sense, which doctor or which hospital, but what happens to me as an individual. Too often, the healthcare system treats conditions, it doesn't treat people. It's engaging with people and the choices all of us have, and we will make different choices as individuals about how we want to lead our lives, and our system isn't good enough.
Our self-determination right. Our self-determination.
Okay, let me stay with communication, but change the tack slightly and ask the question. There's one group within the healthcare system that cannot speak to patients, and that's pharmaceutical companies. Do you think that's a sensible role? That's the same across most of Europe. Do you think that's a sensible ban to have to prevent them talking to patients? It would never be allowed in any other consumer sector of society. Stephen, what do you think about that?
I think it's a proper question. Am I in favor of pharmaceutical companies selling products and making claims to products unmediated through a professional, at public expense, unmediated through the professions? No, I'm not. Am I, on the other hand, in favor of pharmaceutical companies and professional service providers engaging more directly with patients through a full pathway of care and working out what's best for patients independent of traditional models of service provision? Yes, I am. And that's a thought process that is going on within pharma and among some of the leading professionals at the moment. And I think that does offer opportunities to address the points that have been made about better value healthcare delivery, rather than simply selling the latest pharmaceutical compound to the existing service structures.
Michael, do you want to come in here?
Yeah, I mean, there are horses for courses. I think in the United States we see direct-to-consumer advertising. It's a different culture. It works there. I'm completely on board that what we are seeking in Europe and in most other cultures is engagement, is working together across the disciplines, across healthcare, across medicine, across industry, and bring together solutions. I think we've achieved that over the years, trying to make medicines, trying to make treatment more accessible. It's the right way, it's the responsible way in the culture we're living in. That doesn't mean that what happens in the United States is in any way bad. It just reflects a different culture. It works very well there, DTC, or it may not. You can take a view on it, but it is their culture. What we're trying to do is to fit in the culture we're living in here.
Adam?
I'd be very nervous where the drug that is used most is the drug company with the biggest marketing budget. I go and buy the books, see the films, whatever, stuff that's frivolous and doesn't matter, determined on, they're just plastered on buses and, sort of spews into my living room through the television. That shouldn't be the case where the stakes are so high. There needs to be absolute impartiality. As a doctor, you're approached by drug reps the whole time making some reasonably outlandish claims sometimes, and they're all competing claims, all saying mine is best. And you need to have the patient's best interest and decide for yourself, looking at the available data across it, with all your training and expertise. I recommend in your case this one. It's not as simple as go and see Batman.
Fiorella?
I think that patients need to be involved in order for true innovation to happen. But we talk about patients like it's something outside of the healthcare system. There are a lot of lessons to be learned from scientists, researchers who are patients themselves, who suddenly are sitting in the humble chair, understanding how the healthcare could be turned around. I mean, we should be present from the beginning, but the tools need to be facilitated for true patient engagement. And I agree totally that neutrality has to be safeguarded in order to really not deviate from the main interest, which is for the patient life, quality of life. But yes, not to say that all patients need to sit on a board. Not everybody wants that, but there are some patients who know the healthcare system very well because they've been participants on it, or they become very engaged in healthcare system because of their condition, and they learn a lot, and they have the tools to be able to participate at a stakeholder level as a partner in order to really make innovation happen. I believe that this step should be taken.
Thank you, Fiorella. And you've mentioned the innovation word, and that's the next topic of discussion. And we're going to have another clip. And here you're going to see the flight administrator talking to the astronaut's friend, Mathilde.
It's a long shot, but I think we can do it.
Oh, that better be good. We can't keep giving her false hope and then tearing it away again.
I know, but we haven't even tried. It could work, and it's not unprecedented.
Do you need the room? No, you stay. You need to hear this.
Need to know basis, Dawn, but we may have something. Mathilde, can you round up GPO, MOD, and FIDO, and meet back here in 10 minutes.
Yeah.
I'll make a call to RSA.
The RSA. They're just selling overpriced craft.
What the hell's going on, Glenn? I told you this needs to end. What about the RSA?
I get that, but hear me out. The RSA have a few active missions right in the Axiom's quadrant. Exploration stuff, trials. If we're allowed to work with them, we just might be able to pull this off.
Great. Then they can bankrupt us.
Depends on how you look at it.
Go on.
What do you think the effect will be when people find out that this agency had a viable opportunity to save one of their own and did nothing?
As you may have realized from that clip, the flight controller, the doctor, has come up with a very unexpected and innovative way to bring the astronaut home. In other words, to treat the patient. Now, in today's healthcare setting, there's no doubt that we're living through a time of unprecedented opportunity. Genetics, advances in diagnosis, technologies like scanning have opened the way to totally new classes of drugs and new forms of treatment. But at the same time, our healthcare systems are under unprecedented financial pressure. So how do we solve this conundrum? Do we think that innovation is happening too rapidly? Do we need to scale back our expectations or risk creating technologies that we simply can't afford? What would happen if we just stopped innovating completely? So to the panel, I'll ask you all three of those questions, and you can choose which one you answer. Do you think the innovation is happening too quickly? Do we need to scale back our expectations? And what would happen if we stopped innovating completely? Stephen.
Normally when you appear on these platforms, the questions are quite difficult. Those are very easy. Are we innovating too quickly? No. Should we stop innovation? No. We should be looking to facilitate innovation and empower people with properly tested, properly audited ideas. I think the difficult questions come when there are two I want to highlight, seriously difficult questions. First, innovation has to happen somewhere on a day. And that immediately poses the question then, if it's done and works in one place, that immediately creates a demand for it to happen everywhere. And that's where it's how we ensure that innovation that works is then made generally available. That's the first difficult set of questions. And the second, and even more difficult, in particular for pharma, I can perhaps best illustrate by reporting a conversation I had when I went to a GP conference. GPs discussing the latest cancer drugs and how you deal with the latest very marginal advances available from a new drug development. And the discussion around the table, would you, as a GP, do this, take this drug for yourself? No, under no circumstances. It's extra 30 days, it's extra life, but it's not quality life. And so it's the value, going back to that concept, ensuring that innovation, yes, it must be empowered, but it must bring real, not just additional life, but quality additional life.
Adam, do you want to, what does it look like from your perspective on the sharp end?
I mean, it's very strange feeling, wholeheartedly agreeing with a former Conservative minister. But never stop innovating. That's a human thing. That's not a political thing. That's not a country-by-country thing. Never stop innovating. Work out what the innovation is. If it works, then work out how best to deploy it. That has to be the answer.
Okay. Michael.
Yeah, I mean, I wholeheartedly agree. I mean, innovation cannot be stopped. There's a famous story I read as a child that was from Dürrenmatt, and it's about 3 physicists who invent the nuclear bomb and try to hide it by going into an asylum just to be exploited by the leader of the asylum who builds the bomb. It is not possible to stop innovation, but you have to learn to apply innovation in the right way. And I think that's what we have to do together, not in isolation. We don't claim the right to it. I'm sure you don't, I'm sure patients don't, but we have to do it together.
I don't think that the reward system currently incentivizes innovation. For example, cancer drugs only need to do a little better than placebo or a little better than existing drugs. That's not true innovation. And I think that the reward system has to drastically change in order to stimulate real innovation.
Okay, now, if a company comes up with an innovative drug or an innovative piece of technology, the question is the health service, as we have it now, is it ready to take on? Has it got a can-do attitude? Can it take that? This goes really to the second of your questions. How do we ensure that hospitals, insurers in the Netherlands take on that technology?
Well, I think that brings us right back to the concept we talked about at the beginning of value, which is a similar concept, not the same, but it's a similar concept to focus on outcomes. Too often, the health debate is about how many new hospitals we need, how many doctors we need, how many nurses we need, rather than looking at the experience of the patient, the citizen, and how you deliver better outcomes. And what I hope we can encourage within the health debate, and I think pharma can play a big role in this, is focusing on the benefit that can be done. Where the innovation happens, if you can demonstrate benefit, real benefit that patients recognize, then you can create a demand for that to happen. If you wait for the planners to plan it, then it'll happen eventually. But patients are more impatient, ironically, and that's a resource that we should be better at deploying.
Michael?
Yeah, so for us, I think what we have learned over the years, it's I had information working together at a very early stage. So when we have come up with what could be an innovation, what could be a good invention in medicine, that we work with the healthcare system on how can it be trialed, so that when the data comes, patients understand what is their benefit, the healthcare system understands what is the benefit for the healthcare system, i.e. much less usage of bed days, etc., and the doctor recognizes, actually that's how I have to give that medicine to make the achievement. But you know, in the past we used to do that when we brought the medicine to market. Now we're starting with that in mind, with having the right stakeholders on the table when we design, when we come up with new intervention. Doesn't always work, but the aim is there, and we're really trying to see this through 10 years of drug development, very, very steady, to come up with solutions rather than a medicine.
Okay. And Adam, how does it look like from your perspective? In the hospitals you worked in, if a new piece of kit or a new drug came along, were you ready to adopt it and change working practices? And
absolutely. I think you go into medicine, you know, you read all the journals, you want more innovation, you want to be able to offer more, a better outcome for your patients. When I was in my earliest days in obstetrics, a new thing came into labour board. There aren't many advances on labour boards, but it was a way of predicting preterm labour. So lots of people come in, you know, 30 weeks pregnant with abdominal pains, and the question is, are they going to labour or is it something else, and can you just send them home? And this brand new test came in, which was hugely expensive. Now, happily, as often happens, is routine, but at the time, it had just come in. And in order to use it, we had to get sign-off from a couple of senior consultants because it was so much money. And I remember any time a patient came in the middle of the night, if I was the senior doctor on labour ward, I would just do it. Because if it was negative and you could send them home, that saved a patient 2 or 3 worrying days of being an inpatient. And I just thought, it's not my job as the doctor to be withholding something valuable. And what would generally happen is I got slapped on my wrist and told, oh, you do know there's a protocol. I'll go, oh no, I forgot. Because you don't go to medical school, you don't become a doctor to say, oh, there's something that would definitely help you, but I don't think we can do it.
You swore also to do everything.
Yes, I mean, you don't sign the Hippocratic Oath per se, but you definitely uphold its ideals that you want to do everything you can for a patient.
Okay. Let me ask, we're going to move on and talk a little bit about the future now. And I'd like to ask you, the two of you in particular, and I'm going to single out pharmaceuticals again, which isn't going to suit your position, but in this country and actually across much of Europe, the drugs bill for national health services is around about 10% of the full cost of care. Now, is that a significant, is that such a large amount that we should be focusing on it so greatly?
Yes, I think the short answer to that is yes, it is a large amount of money. It's something, it's I think around £12 billion currently, which is, it's a lot of money. And I think taxpayers and patients and professionals actually would expect the system to test pharma, to insist, first of all, that the price that's paid for an individual pharmaceutical product is a fair price, and secondly, that we don't buy pharmaceutical products that don't deliver significant value to patients. So both of those tests, I think, are important. But looking beyond that, I said right at the beginning, I think the mistake we too often make is to look at the money spent on drugs within the health budget as somehow different from the money we spend on facilities, the money we spend on staffing and all the other things, and say, well, we have to focus in particular on drugs. Actually, what we should be doing is looking at the experience we deliver to patients and what's the most efficient way of doing that, which may involve changing the balance between drugs, facilities and staffing and other things, and looking at the whole cost rather than just focusing obsessively on one cost.
Okay, well, I'm going to focus obsessively on one cost for the moment, because Michael, in a sense, pharmaceuticals is unique in one aspect, I would argue, and that is that you can't just pluck a drug that you require at that time off the shelf if it hasn't been developed. So pharmaceutical companies are thinking many, many years in advance.
Can I say, I mean, of course I understand that, but you can't pluck a doctor off the shelf either.
Okay, well let me ask Michael, can you just explain how pharmaceutical companies have to deal with this issue of what's going to happen in the future?
Two things about cost. So we also think that what you said about looking at cost brings the value argument, and it helped us as an industry tremendously to focus on what we develop. So in fact, we're grateful for it. I mean, I think of the 12 billion, to be fair, only 6 billion are spent on innovative medicine, 6 billion on generic medicines. But if I know the NHS situation correctly. But as an industry, clearly the problem we have is not so much cost, it's to identify what is the need, what for value in 10, 15 years' time. So the problem we have is, it's like if you have your favorite Premiership football club and you have to place a bet on them to win the league in 15 years' time. It is an issue of timing we have. So we are not shying away from making huge investment up front, but the uncertainty is something nobody likes, and we are public companies, so it's part of my money, but it's also clearly part of your money, and you don't like me telling you that I have no whatsoever guarantee that I will give you anything back in 15 years' time. So that is one of the problems we have to deal with together. And to be honest, the scrutinizing of cost and value, I believe, has made this industry a better, more productive, sharper industry. So I think in the end we're grateful for it, but let us be a partner in determining value and value frameworks.
Okay, let me ask the question a slightly different way of everybody, really, and that is that in a sense what we have here are three groups that have a similar but slightly different priority. So we have the patients who want to get better at any cost. We have the doctors and the health service administrators who want the patient to get better at a cost that they can afford, and we have the pharmaceuticals industry which wants the patient to get better, and they need to make money in order to do so. Now, do you think it is possible to reconcile those three priorities? Do you think we're doing it right now, or is there a better way to do that? Stephen?
Is there a perfect solution? Is this a problem you can solve and put in the cupboard and say, okay, sorted? No. the word that's used is dialogue, partnership. This is a real-time conversation. And the nature of the conversation changes because the conditions of the patients that present change, the science changes. You've mentioned the introduction of a better understanding of the human genome. That will fundamentally change both the nature of the pharmaceutical product that is offered and also, even more importantly, the nature of the treatment structures that are necessary to take advantage of that science, not to mention the regulation and so forth around it. So can we produce a solution that, as I say, sorts the problem? No, we can't. But what we have to do is to ensure that there's a continuing dialogue and that we recognize, I interrupted you perhaps, what we have to recognize is that, of course, pharma has a long-term requirement to invest in science and to build a sustainable business. Incidentally, there's an economic interest for the United Kingdom in ensuring that that's a successful industry that goes on here. So pharma has that interest. But if we want staff that are able to use pharma products, then that's a long-term investment in understanding the changing shape of healthcare. And we need different facilities, and we need to engage communities in all the choices that are made in the course of that dialogue.
Okay. Fiorella, do you want to sum up?
Well, I think that what you were saying, I wanted to say something to join what you were saying. Yes. What I think is that the benefit right now, and I don't say specifically all pharmaceutical companies operate this way, but the pharmaceutical as a whole has created a system in which we cannot justify the cost of some medicines for the innovation that they bring. When we switch to a debate more of what really is delivering, it's bringing this innovation for patients and pay for that, then I think it's more constructive. But it's not that patients are strange to this conversation. I mean, I hear of all patients feeling guilty that they know that a medication they take are 80,000 euro or something like that, and patients are having these concerns as well, and I don't think that's fair. So I think that if we talk more about the value that drugs yield and what they cost and the innovation that they bring is more in line with each other, then of course we need the drugs, so they may cost money.
Michael, what does it look like from your position?
Yeah, I mean, I think we long realized that we live in the same ecosystem, in the same pond. And as you said, the dialogues change. Now, what innovation is for some and innovation is for others. And it's difficult to compare saving a life through a cheap antibiotic vis-a-vis making an advance in a cancer setting. And many advances in a cancer setting come together. So one drug may be a little advanced, still costs the same. But two drugs of the same kind may be a huge advance, still cost the same. So it's a changing dialogue. I think we're in complete agreement, but we are part of the same ecosystem. We are not wanting to get out of it. We're wanting to live in it, but we want to be seen as a partner. And this is why we tried, I think, this unique approach, because we go everywhere and we're sort of seen as the alien from outer space. We are not. I think we are very much recognizing what is happening and make us a partner.
I must say that I appreciate that very much from the video. To see the struggle of the experts themselves and trying to get the patients or trying to go beyond. And I think that dedicated professionals do have a great impact here, because in case of the fact that something cannot be given, but they decide to do so, it just makes all the difference for that person. And just bringing out how difficult it is also to try to reconcile all these things, I think is a good step in the right direction.
Adam, what about this idea of overlapping but different priorities?
Everyone's ultimately got the same priority, one hopes, which is the best interest of the patients. Doctors obviously do. Don't put doctors in the position where they have to say something they don't believe. It's a nightmare to say to a patient, this is what I recommend, and not and actually mean this is what I'm told to recommend, not this is what I believe. I would say to patients, you have not met the criteria for infertility treatment, but write to the chief executive of the hospital and write to your MP and write to the clinical commissioning group, because people who kick up a fuss do end up getting stuff that isn't quite on the algorithm. But a lot of people just say, I'm afraid, break it as bad news, and that doesn't feel right as a doctor, and I think it does involve more joined up thinking between all the professions involved.
Okay, right. Thank you very much, everybody. We've come to the end of this debate, and perhaps I can just sum up with some of the thoughts that have occurred to me, well, actually, that these guys have supplied, and that is, it seems to me that we need to monitor all aspects of healthcare and the way our society works, not just drugs, not just prevention, but everything in the whole. Patients need a deeper involvement in deciding healthcare decisions. And we should reward significant benefits to patients, and that includes the quality of life, not just extending life, perhaps. We need a continuing dialogue, and I hope that this has been a good start towards creating that dialogue. And for anybody going to a doctor tomorrow, perhaps the question you should be asking your doctor is, would you take this treatment? Because it seems to me from what Adam said and what Stephen said, that that's a good acid test for whether the doctor believes in the treatment you're about to get. So let me just recapitulate. You can see the film This Is Axiom on the Celgene stand. It's stand 1121. It's right behind us here now. Or you can watch it on YouTube. So I'd like you to thank our panelists, please, in the normal way. Thank you very much, everybody. And before I go, I guess there are two other thank yous. One is to Celgene. I'm a science journalist, so it's very rare for me to praise a pharmaceutical company, I can tell you. But this is a very courageous thing to do, to put themselves up in front of the public on a discussion like this. And of course, I'd like to thank you for coming this morning. So thanks very much.